Today we're coming to you live from the American Orthopaedic Society for Sports Medicine annual meeting in Seattle, Washington. The AOSSM annual meeting is the premier sports medicine conference each year, hosting thousands of attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine. Over these 7 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the meeting. These episodes are brought to you by Arthrex, a global leader in minimally invasive orthopedic technology and surgical education. We appreciate their continued support of this podcast, as well as their commitment to advancing innovation in sports medicine and helping surgeons develop technologies that continue to improve patient care. Cartilage restoration and knee alignment are becoming increasingly connected in the world of joint preservation. In this episode, Dr. Krych of the Mayo Clinic discusses today's approach to joint preservation, from cartilage restoration techniques using technologies like AutoCart and osteochondral allografts, to the critical role that osteotomy can play in protecting and preserving cartilage repairs. He'll also explore how Arthrex patient-specific instrumentation, or PSI guides, help surgeons plan and execute osteotomies with greater precision, allowing alignment correction to be tailored to each patient's unique anatomy. With more than 40 years in minimally invasive surgical technology, Arthrex is a global leader in sports medicine and orthopedic innovation, helping surgeons treat their patients better. Learn more at arthrex.com.
So we're going to introduce and welcome our guest, Krych, who is back on our show today, and we're very excited.
Yeah, welcome.
Thank you for having me.
So 10 years ago, our conversations primarily revolved around microfracture and OATS. And now today we're discussing biologic augmentation, single-stage cartilage restoration, osteochondral grafts, and then patient-specific instrumentation for osteotomies. So really the treatment options have exploded. But with that greater complexity comes even more complexity in our decision-making.
So choosing the right operation for the right patient is arguably the most important thing. But before we get into that, let's start with the beginning. So let's talk about focal cartilage defects. So how has your approach changed over the last 5 to 10 years?
Well, I think when you look at 10 years ago as a benchmark, we've really evolved to thinking about focal cartilage defects to entire joint preservation. So things like alignment, meniscus preservation, and it's a remarkable time to be a cartilage surgeon because we're doing better for alignment correction. We're doing better for meniscus preservation. Think about 10 years ago, PRP and orthobiologics were not mainstream. So we have so much more data, so much more evidence, and more options available, like you said, which can make it confusing in terms of decision making,
Sure.
But also helps really think about joint preservation and how do we treat the patient? How do we treat the symptoms? How do we really get the best outcome possible?
Yeah, and it seems like our understanding of the natural history in terms of progression of cartilage damage has also evolved. Do you feel like our threshold for recommending cartilage restoration has become lower or perhaps more aggressive because we understand that trajectory of a cartilage lesion?
Yes, and I think patients are more aware of what their choices are. So I think previously a patient would come in for knee pain and it was a little bit broader of a discussion. Now patients are so educated, they come to us and they know about several different cartilage treatment options and they're wanting to talk about the nuances of each one. So yes, I think that part, patients are more educated, which really makes, I think, our jobs easier because a lot of it before was trying to really get them to understand this is a process. We're trying to preserve the joint. And now they come in and they get it and they're pushing us to preserve their joint. They don't want to progress to metal and plastic. So they're really willing to invest, I think, the time up front for the best treatment option, not only to get better now, but to think about the future of their joint. So in some ways, that threshold has changed just because I think patients are better educated and they come to us, with the discussion, which really, again, I think is an exciting time.
It's a good thing.
Yeah, exactly.
Yeah, absolutely. And you had mentioned there's a lot of options out there. So that leads perfectly into what we want to ask you next, which is, Aaron, can you walk us through a little bit of your algorithm and how you think about all those options, whether it's patient factors or lesion factors?
Yeah, so I think you really have to be systematic, when the patient comes to your clinic. So it starts with why. Why did they develop this cartilage lesion? We all know there are some traumatic cartilage lesions that people can have. Maybe it's a kneecap dislocation or a sudden injury, but most of these are evolving acute on chronic picture, if you will. So really being dogmatic about assessing the alignment, assessing their meniscal status, what's their stability, trying to figure out, again, why did they get into trouble? If we start with the why, then we can really put together a plan, and then it gets down to a specific cartilage treatment. And there, I think many factors are important: size, location, anticipated demands, time for recovery. And really, it's about individualizing the treatment plan to the patient, and it's precision medicine. I think we have more data to help make and drive those decisions, and it's really fun because if you get an educated patient, you can really have a quite nuanced discussion. But the good news is we have options.
Yeah, that's great. Now, you mentioned size of the lesion contributing. So, historically, Catherine and I in residency, we had these charts, right? Less than 1 centimeter is this, 2 centimeters is this, greater than 2 is this. Are you still using strict size cutoffs to determine cartilage treatment?
I think the lines have blurred a bit on sizes. For example, go back to 10 years ago. So osteochondral allograft, for example, wasn't always used for a primary option. It was considered a salvage procedure, et cetera. But what we've learned over time is if you have a condylar lesion, probably a bone and cartilage option does better for it, regardless of size. So in those high traffic, high weight bearing areas, we are choosing, an osteochondral allograft, even if it is, a little smaller than what we would considered that 2 centimeter cutoff previously.
Yeah, and let's talk a little bit more about how you determine the factors around that lesion. So whether it has subchondral edema, the size, the location, obviously MRI technology has also evolved so we can get a lot out of our MRI, but we also have the ability to do diagnostic arthroscopy. So how much are you doing that diagnostic arthroscopy to really make your decision?
Yeah, and I think it comes down to, complementary information and the right context for the patient. So sometimes an MRI is enough. It gives us great, information about size, dimensions, subchondral bone, as you talked about. Other times the cartilage lesion is there because they have a 2-time failed ACL, and there's a question of meniscal deficiency. If there's ever a question of what variables you're dealing with, then I think a scope becomes a very valuable tool, because you never want to go in on a cartilage lesion thinking you have meniscus that you can preserve, and then all of a sudden you get in there and 25% of the meniscus is remaining. You can fill that cartilage defect, but the chances of it failing are much, much higher. So I think for the right patient, diagnostic arthroscopy, doing a first stage, kind of getting a lay of the land, can be very helpful, but we don't always reflex to 2 stages if needed, because patients want to recover quickly and get on with their lives as well.
Absolutely.
Now, we've been hearing a lot about nanoarthroscopy at this meeting. So what are your thoughts on the use of a nanoscope for a diagnostic evaluation prior to a cartilage procedure? You mentioned patients don't really want to go through 2 procedures. Perhaps that less invasive nature might be more appealing. What are your thoughts about that?
Yeah, so nanoscope, again, is a new tool that we're trying to figure out exactly the complementary information it gives to us. But to be able to dynamically look at the surfaces of something in clinic, through nanoscope really is an advantage. And in the pre-op setting, it can be helpful. I find it also very helpful in the post-op setting.
Yeah.
Maybe someone isn't doing as well as they should. You get an equivocal MRI, there's post-operative change there. What does that mean? So sometimes there a nanoscope can be very valuable. You get confirmation, and it's a great experience. I don't know if you're doing these in your clinic, but the patient can watch with you. You can explain the findings, and they really love that valuable feedback. And again, they walk out with a Band-Aid, which is quite remarkable.
It is really remarkable, even over the last handful of years with the next generation, it's pretty incredible the quality of the imaging that you're getting.
The quality has gotten so much better.
Yeah.
So we started early. We were doing a lot of research studies, kind of looking before and after some stem cell injection treatments. And we went through about 3 or 4 iterations of the technology over 10 years. And the nanoscope is a game changer because it really, you get a crystal clear picture. and the patient can see it with you. It's just, again, it's a really neat kind of shared experience.
That's great.
Yeah, agree.
What if you could get gait laboratory insights from a simple foot insole in just 3 minutes? With Ballaston Health's AI MoveScan, you can. AI MoveScan brings clinical grade movement analysis directly into everyday patient evaluations. Simply place the sensorized insole into your patient's own shoe and have them walk, run, or jump naturally. There is no complex setup, no calibration, no markers, and no treadmill required. In less than 3 minutes, you receive a clear, actionable report with more than 30 validated biomechanical parameters to help evaluate movement quality, monitor rehabilitation progress, and support more informed treatment decisions. What makes the platform even more powerful is its integrated AI assistant. Built within a closed model, the AI assistant helps clinicians better understand the movement data, identify meaningful trends, and connect objective biomechanics to clinical decision-making. And the results are backed by data. AI MoveScan has demonstrated 95% agreement with optical motion capture, which is the research-grade gold standard in peer review validation. Whether you are evaluating recovery, monitoring progress, or helping guide return-to-play decisions, AI MoveScan brings objective movement data and AI-supported insights into everyday clinical practice. To schedule your personalized demo, email sales@bracelab.com and mention the sports docs. Learn more at bracelab.com. Every patient has a goal: getting back on the court, returning to the trails, staying active with family and friends. At JRF Ortho, they are proud to help surgeons make those goals possible through industry-leading allograft solutions and one of the largest inventories of fresh osteochondral allografts available. For more than 20 years, JRF Ortho has partnered with surgeons to restore damaged cartilage and bone using fresh OCAs that contain living hyaline cartilage and viable chondrocytes. By preserving native joint mechanics, osteochondral allografts continue to play an important role in joint preservation and helping patients maintain active lifestyles. With more than 30,000 allografts distributed worldwide, JRF Ortho is trusted for innovation, superior customer care, and the highest quality products. And they make ordering JRF Ortho easy. Whether you have a specific surgery date, a preferred date range, or simply need the earliest available graft, their dedicated allograft solutions coordinators work with you every step of the way to identify, match, and deliver the right graft for your patient. From femoral condyles, talus, patella, distal tibia, to meniscus, tendons, and OCA cores, JRF Ortho provides the grafts, the experience, and the support that you need to move patients forward. JRF Ortho, 20 years of excellence in motion. Visit jrfortho.org to learn more.
So AutoCart has generated tremendous excitement as yet another single stage treatment, as Catherine was talking about. We want to talk about those single stage, save that patient that second surgery, but this time using their own cartilage. So what is AutoCart for our listeners, and what is the appeal of that versus other cartilage treatments?
Yeah, so AutoCart is taking the patient's own cartilage, and it's using the shaver to essentially mince that cartilage, and it can be implanted, just as you said, in one stage. We don't have a lot of one-stage options, so I think this is one where, it's hyaline cartilage, it's the patient's own tissue, and you can deliver it at the same time. So really remarkable in that fashion. More and more data is coming out. We're lucky here in the U.S. we have multiple options with osteochondral allograft and some of these other technologies, but our colleagues in Europe, for example, have much more experience. They have longer follow-up and data with this autograft minced cartilage, and the results are quite promising. We're seeing some 5 and 10-year data now that for small to medium lesions, we're seeing quite good ingrowth and improvement in patient outcomes, really that rivals some of the more expensive two-stage, cartilage growth technologies.
That's great. Very promising.
Very cool. And, we have a lot of residence fellows, young surgeons that listen to our podcast. So any sort of technical surgical pearls about that procedure that you can share?
Yeah, so there certainly is a little bit of a learning curve. I think we've been used to doing more open cartilage surgery as we evolved away from microfracture arthroscopically. Now the generation of surgeons we're training, they're used to doing the defect preparation open. So that's how I'd recommend to start, is just do a case or two open, get a perfect defect preparation. You can still mince the cartilage, with your shaver, but then you can really see what you're doing. once you get one or two cases open, then evolve to arthroscopic. The key is trying to figure out how to get a dry, arthroscopic environment. And there's a variety of tools with suction and different things that can help. That comes in the kit with AutoCart. But then really just being able to deliver it, not overfilling the defect, is a good, learning pearl. When we started, you think more is better, but actually underfilling the defect a little bit, maybe even taking it through a range of motion, making sure it's stable as you're doing it arthroscopically can be very helpful. But usually by 3 or 4 cases, you've kind of gotten through the learning curve. And again, it's quite efficient, single stage. It's a cheap technology, thinking about cost to our healthcare system as well.
Yeah.
Can you talk a little bit about the harvesting of the cartilage? What are you using to harvest that cartilage, and where do you prefer to take that healthy cartilage from?
Yeah, so the cartilage we can harvest arthroscopically. So we put a graft net, which is essentially a filter on the back of our shaver, and then the shaver actually minces the cartilage tissue for us. So typically I'll take that from the defect itself, any loose cartilage, cartilage surrounding the defect. And then if you don't have enough to fill the defect, then you can take from the traditional biopsy site. So whether that's around the notch, whether that's on the proximal lateral trochlea, but usually you can get enough harvest. What's been fun about the technique, we think about cartilage in the knee, but in the other joints, this has worked really well. So a lot of good data coming out on ankle, hip joint, which really is a difficult arthroscopic joint to treat. Now having an all arthroscopic way to collect the cartilage, mince it, mix it, and put it back into the joint just through the scope, minimally invasive, I think, again, has just been one of those evolutions of treatment.
That's great.
Yeah, I agree. Thank you for bringing up the ankle and the hip. I think that's a great point. We do focus a lot on the knee with cartilage, but I think those are great options as well. So as far as our other single stage procedures, whether it's an autograft OATS procedure or we're thinking about an allograft OCA, now how do you make those decisions? Now we have a couple different options to choose from. What sort of puts you in one direction?
Yeah, so I think going back to what you talked about, bone really is important. So really knowing your MRI, studying your MRI. If there's cystic changes in the bone, if we're seeing chronic edema, those sorts of things, we do lean a little bit more towards a bone and cartilage solution. For an autograft transfer, you won't be performing many of those in a year. But if you do have a small lesion that's symptomatic on the condyles and you can transfer 1 or 2 plugs, that is a home run because it's the patient's own tissue. It heals quickly. Sometimes those patients can get back to sport as early as 6 months, which is fantastic. Once it gets a little bit bigger and now you're robbing too much from Peter to pay Paul with donor site morbidity, then we think about the osteochondral allograft. And again, compared to 10 years ago, now these have really become mainstream primary treatments for a condylar lesion. Anytime I see bone edema, cystic change, that becomes a very predictable option.
Yeah. Absolutely.
Now, you highlighted at the start of the episode that we think of cartilage restoration now as total joint preservation as opposed to just looking at the defects. We want to talk a little bit about alignment and osteotomies. So alignment really is a critical part of our cartilage restoration conversation. We can't dive too much into it, but we do want to ask for a condylar defect. How do you decide which patients should undergo an osteotomy? Because obviously it's added surgical time and recovery, and which patients may be able to get away without one.
Yeah, it's a great question, and I look for this on every single patient, and I'm happy when I see malalignment. If I see malalignment as a cause for why this cartilage is failing, then I know we can reverse that. Because again, we think about the focal lesion, but it's really the entire compartment. So on the medial side, to me, 4 to 5 degrees is a threshold for an osteotomy, and that will offload it approximately 20 to 30%. On the lateral side, that threshold goes down to about 3 or 4 degrees, where you start overloading things 20, 30%. So that's what I look for. And if I see it, I have a conversation with the patient. And again, I'm happy I see it because osteotomies have gotten so much better, so much more precision over the last 10 years.
Yeah. Yeah, I think that's great. And as far as when you're making your actual plan, so some will do their osteotomy and a diagnostic scope at the same time and do a second stage for the cartilage. Others say, nope, I just want to get it done in one stage for this person, and they'll do an OCA and osteotomy at the same time. Where do you fall in that spectrum?
Yeah, so I'm going to side with my patients, and if you have a good discussion with your patients and you walk through two theoretical timelines, time off of work, time away from, just with recovery and everything else, many patients will choose one-stage surgery.
Yes.
Now there is a risk, right? It's you can have a little bit more of a pain response.
Sure.
It can be a little bit longer time on crutches, a little bit, higher chance of stiffness. But really, I think one stage now, just with the way we're doing osteotomies and cartilage, is the way to go in most cases.
Yeah.
Now, let's talk a little bit more about patient-specific instrumentation, because that's a hot topic at this meeting as well. So are you using PSI guides, and how does this compare to traditional freehand that was used prior for osteotomies?
Yeah, PSI has come on strong and is really taking over osteotomy market. And really, it's about precision. We don't want to undercorrect. We don't want to overcorrect. That's a big deal to put your patient through that and then not hit your intended target. So really, the PSI has helped us to hit the target. And again, we're shooting for neutral, mechanical alignment in most of these cases. But, it also, I think, helps extend a useful tool into more hands. Some people may not be comfortable with an osteotomy. They only do a few per year. I think this makes it much easier, more efficient, and safer for the patient.
Yeah. And I think those are all great points. And I had already indicated we have a lot of young listeners as well as more senior folks listening, and we have a patient population that listens as well. One thing that I know our listeners love is really understanding lessons learned over time. We've touched on a little bit the evolution of what's even available to us. But as far as you as a surgeon, Aaron, what have you learned over time that you fine-tuned and you can share with our audience?
Yeah, I think we're coming full circle. We started the conversation, and it's entire joint preservation. So a focal cartilage defect is rare and uncommon. So look for those other things. Look for malalignment. Look for meniscus deficiency. Don't be afraid to address those underlying causes. The second part of it is just over time developing, you really want a great relationship with the patient. These sometimes recoveries, take a little bit longer. Sometimes at 6 weeks, I feel a little bit more like a psychologist in my post-op rechecks, saying it's going to be okay. You're doing fine. You're doing well. And then they kind of get through it. But it's nice to have that relationship. I enjoy walking the journey with the patients, but they need to know that up front. So I think those are the two things, looking for all those background factors and treating them, and then really just having a good conversation, having the patient understand what they're getting into.
It's a big deal.
Yeah.
Absolutely. Well, this has been a great discussion. Thank you so much for joining us today. Back on the show again. Thank you.
It's been great being here. Thanks for having me.
Yeah, we've had you, I think, three times now. And
I feel very special.
You're one of our favorite guests, and one of our most popular guests, as far as I think you do a really amazing job of distilling down really difficult, complex material into things that everybody can understand. So we really appreciate having you.
Thank you again.
Thank you.
Thank you.
Thank you for listening to this episode of the Sports Docs podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love your feedback.